The United States spends more on healthcare than any other country in the world. Not by a little, by a lot. We spend nearly twice as much per person as other wealthy countries. Healthcare alone now takes up close to 1/5 of the entire US economy. But here's the part most explanations miss. Americans don't use twice as much healthcare. So if it's not how much care we use, where does the money actually go? When healthcare costs come up, the explanations are usually familiar. Some people blame government bureaucracy. Others blame insurance companies. Some blame hospitals, drug companies, or unhealthy lifestyles. And to be fair, all of these play some role. But none of them explains why the US is such a massive outlier to other wealthy countries. Because if any of those were the main driver, we'd expect Americans to be using far more healthcare. And we aren't. This is the most important distinction in the entire conversation. Total healthcare spending is just two things multiplied together. How much care people use times the price of that care. So let's look at both. When you compare the US to other developed countries using data from the OECD, Americans are roughly average on doctor visits, hospital stays, and medical procedures. In some cases, we actually use less. But when you look at prices, the cost of an MRI, a hospital stay, or a routine procedure, the US stands out immediately. Same services, very different prices. That's the core of the problem. Healthcare in the US is expensive primarily because prices are high, not because Americans are using dramatically more care. I've talked about pieces of this in a few short videos already, but this is where it all comes together. So now let's talk about how healthcare pricing actually works, because this is where things get counterintuitive. Healthcare pricing doesn't work like a normal market. There usually isn't one price for a service. Often, there isn't even a posted price. Hospitals and insurers negotiate prices privately. Those prices are usually confidential. They vary by insurer, by hospital, by location, sometimes even by plan. Patients rarely see the real price point at the point of care. Providers often don't know exactly what they'll be paid until after care is delivered. So prices aren't discovered through open competition. They're negotiated behind the scenes in a system where patients are insulated from prices, providers want predictable revenue, and insurers are managing risk, and no one's shopping around for the cheapest option. Over time, that structure pushes prices upwards, even without bad intentions. This effect gets stronger as healthcare consolidates. Over the past few decades, hospitals have merged into larger regional systems. When a hospital system controls most of the beds in an area, it has more leverage when negotiating with insurers. And when insurers consolidate in response, the negotiation becomes less about competition and more about who has leverage. So what does the evidence show? Research from the National Bureau of Economic Research consistently finds that hospital consolidation leads to higher prices, with little or no improvement in quality. This isn't about greed, it's about incentives. When leverage increases, prices rise. So what about prescriptions? For the purposes of this video, I'll only specifically talk about medications administered inside hospitals. Things like IV antibiotics, chemotherapy, anesthesia-related drugs, or emergency treatments. Outpatient prescription drugs are a different system with different incentives, and I'll cover that separately. Here's the issue. Hospitals don't usually bill insurers for these drugs at acquisition cost. They bill using hospital charge structures, often based on internal markups that have little to do with what the drug actually costs the hospital. In many cases, hospitals charge several times the acquisition costs of the medication. Why does this happen? Because hospital drug charges are folded into the same opaque pricing system as everything else. List prices that almost no one pays, negotiated discounts that vary by insurer, and patient cost sharing that could be based on those inflated charges. For patients, this often shows up as high coinsurers, large bills even when the drug itself isn't rare, and little ability to shop or compare in advance. This isn't because hospitals are uniquely malicious. It's because, in a system where prices aren't standardized, markups become a way to recover revenue, especially as hospitals negotiate lower payments elsewhere. And once again, the pattern holds. This isn't about using more care. It's about how prices are set. This is why healthcare feels so frustrating at the household level. Premiums rise even when your care doesn't change. Deductibles go up. Bills feel arbitrary. And shopping around rarely works the way people expect it to. If this system feels confusing and unfair, that's not a personal failure. It's a design problem. So what can actually be done? One of the most common answers that we hear is transparency. The idea is simple. If patients can see prices, they can shop, and competition will bring costs down. That makes sense in theory, but healthcare doesn't behave like most consumer markets. Most care isn't shoppable, most decisions happen under stress, and even when prices are available, patients usually aren't the ones controlling the biggest costs. Insurers are. Analysis from the Congressional Budget Office shows that transparency by itself hasn't produced large system-wide reductions in healthcare spending. Transparency can help at the margins, but it doesn't change how prices are set. Another major attempt to fix healthcare focused on insurance. through the Affordable Care Act. The ACA did some important things. It dramatically reduced the uninsured rate, it standardized insurance benefits, and it limited how insurers could price plans based on health status. Data from the Kaiser Family Foundation shows that tens of millions of Americans gained coverage after the ACA took effect. But here's the key point. Expanding insurance coverage doesn't automatically lower healthcare prices. In the individual market, premiums rose sharply in the ACA's early years, largely because insurers were now covering a broader, sicker population while still paying the same underlying provider costs. The ACA changed who was insured. It did not fundamentally change how prices are set, so costs kept rising, just more evenly spread. That brings us to approaches that directly target prices themselves. A clear, real-world example is Maryland. Maryland uses an all-payer hospital system where hospitals are paid the same rates regardless of who the insurer is, whether that's private insurance, Medicare, or Medicaid. Instead of negotiating hundreds of different prices, hospitals operate under a standardized rate system. So what happened? Hospital spending growth per admission in Maryland has been consistently lower than the national average, and peer-reviewed evaluations published in the journal Health Affairs find no evidence of worse patient outcomes or reduced access to care. In fact, some outcome metrics actually improved. Maryland isn't cheaper because people use less healthcare. It's cheaper because prices grow more slowly, and because the rules apply across the entire system, limiting cost shifting between payers. So if you take one thing away, it's this. Healthcare in the US is expensive not because Americans are uniquely unhealthy or because one group is uniquely bad, but because of how prices are set throughout the system. If we want lower healthcare costs, the evidence suggests that we need to focus less on blaming individual actors and more on changing the pricing structures that shape everyone's incentives.